Thank you everyone for joining us today. This is the latest webinar for the PARC study. I'm one of the co-principal investigators of the PARC study. I just want to mention that I have returned from Europe yesterday, where I had a very productive meeting with autism researchers and clinicians from around Europe who have expressed a very strong interest in learning more about this specific study, the pediatric autism research cohort study. And one of the topics that kept coming up at this meeting in Italy was related to this exact webinar, understanding and supporting autistic children's mental health. So I'm delighted. This is a timely presentation by two leading experts in the field. Dr. Beth Kelley and Dr. Caroline Roncadin, who are both co-investigators on the PARC study. I will now read the introductions for our two speakers. Dr. Beth Kelley is an associate professor in psychology and psychiatry and a member of the Center for Neuroscience Studies at Queen's University. She completed her undergraduate degree in psychology at York University and received her PhD in developmental psychology from the University of Connecticut. Dr. Kelley has a wide range of research interests related to both typical and atypical child development and has published in a number of prestigious journals, including Child Development, Current Directions in Psychological Science, and Nature. She has been funded by the National Institutes of Health, the Canadian Foundation for Innovation, NeuroDevNet, Ontario Brain Institute, the Canadian Institutes for Health Research, and Social Science and Humanities Research Council of Canada. Dr. Caroline Roncadin has been a licensed clinical neuropsychologist in Ontario for over 20 years. She completed her master's and PhD at York University and her postdoctoral training at the Hospital for Sick Children. Currently, she is the clinical director of the autism program at McMaster Children's Hospital, where her work focuses on training community professionals to diagnose autism and on developing and evaluating new care pathways and service models for autistic children and youth. Dr. Roncadin is also the co-director. She's my co-director at the McMaster Autism Research Team. Her research interests are in early detection and supports for autistic children and their families. She has published in top-tier peer-reviewed journals and has delivered numerous invited talks at provincial, national, and international conferences. More recently, Dr. Roncadin has become actively involved with the National Autism Network and aims to help shape policies and practices that will improve the living experiences of autistic Canadians. Thank you both for accepting the invitation for this webinar, and we look forward to your presentation. The floor is yours.
I want to welcome everyone to this talk and hope that it's beneficial for everyone. We'll be discussing depression, anxiety, obsessive compulsive disorder, and ADHD today, as these are the most commonly occurring mental health conditions in childhood. Given the PARC's focus on childhood, we decided to limit it to mostly for childhood. For each condition, we will talk about what it looks like in children, how it may look different in autistic children, and how these conditions affect development and functioning of the child. We'll also provide some practical strategies and resources for parents. Please note that we will use identity first language throughout this presentation, that is autistic child rather than child with autism, as this seems to be the term that is most preferred by the autistic community. So as a disclaimer, we will provide an overview just of the most common co-occurring conditions. We will focus on childhood and not adulthood. Not all of the content may be applicable to your child, and we have tried very hard to include general strategies and resources that are helpful for a broad range of children, and families. So the first thing we'll talk about is depression. So To be diagnosed with major depression, individuals must have at least 5 symptoms from this list. Because autism and depressive symptoms may overlap, these symptoms have to be new to the child or at least different from their average functioning, and they must persist for at least 2 weeks. Oftentimes, children will not show clear depressed mood, but instead show what we call anhedonia, which is the loss of interest and pleasure in activities that were formerly pleasurable. This can show up in autistic children as a decreased interest in engaging with their special interests if they have them. There are many physical symptoms of depression, which can go either way: weight loss or gain, insomnia or sleeping too much, being restless or lethargic, and extreme fatigue. Cognitive differences may be less common in children, but include feelings of worthlessness or guilt, concentration troubles, and extreme indecisiveness. Some individuals will have recurrent thoughts of death or desire to commit suicide. So depression can look very different in children than it does in adults. Young children will often be very irritable, clingy, and have frequent headaches or stomach aches. They may incorporate themes of death in their play. As they get older in late elementary school, they may still show a lot of signs of irritability, and it's important not to treat this as defiance. Children may be more impulsive, have troubles in school where they didn't before. They may also withdraw from their friends and family. In high school, it's common to see a general lack of motivation, leading to a lot of academic problems. These young people, especially girls, may engage in cutting or other self-harm behaviors. This is because physical pain actually makes their psychological pain more tolerable. These behaviors have to be dealt with very carefully because they are providing some measure of relief, so it's better to leave that up to their doctor or therapist. Just like any neurodevelopmental or mental health condition, there are positive aspects. Many people with depression show increased creativity and thinking outside of the box. Depression in youth can also lead to increased resilience, such that they become more able to deal with adversity in the future. So there are currently no screening measures that are designed specifically for autistic youth. And this is problematic because there is significant overlap in symptoms between autism and depression. Parents, teachers, and even healthcare professionals may engage in what is known as diagnostic overshadowing. This means that when new symptoms come up, they may just attribute them to the autism and think that there is nothing further to be done. But of course, this is not true. Youth with a higher IQ and older age, as well as lower levels of autistic traits, are at greater risk for depression. And this is likely because they're more aware of their differences and their struggles. As mentioned earlier, there are signs of depression that overlap with typical autistic traits, such that they may be mistaken for them. Social withdrawal is common in both autism and depression, although autistic youth experiencing depression will likely show an increased level of social withdrawal from their baseline levels. Anhedonia, or as mentioned, the loss of interest in previously pleasurable activities or interests, is common in depressed youth. Autism and depression both lead to sleep disturbances, but if sleep disturbances are worsening in your autistic youth, it is possible that this is due to depression, although sleep disturbances can be caused by other things as well. Youth who are more severely impacted by their autism and or have below average IQ may lose skills that they had previously mastered, such as self-help and toileting skills. They may also show increased stimming and increased self-injurious behavior, such as self-hitting and headbanging. Major depression generally shows fairly dramatic change in behavior from the child's normal behavior. That is not to say that a slow onset of behavioral change is not cause for concern, but may indicate a more mild form of depression. To be given an official diagnosis of major depressive disorder, the symptoms must be impacting their ability to function in the world on a daily basis. Many parents may be afraid to talk to their child about their feelings for fear that they might make their feelings worse. This is definitely not something that you have to worry about. Whatever you do, try your very best not to deny or downplay your child's feelings. They need to feel heard and understood. If the symptoms do not improve within a couple of weeks, then contact your family doctor for a referral. Family doctors and/or pediatricians are generally not comfortable in providing a depression diagnosis in a child with a neurodevelopmental condition. While you're waiting, try to get them outside and active as much as possible, as fresh air, nature, and exercise can reduce symptoms significantly. Try to keep track of how much they eat and sleep and encourage them to do an appropriate amount of both, as this will improve their symptoms. It's also important for them to get social interaction, so gently encourage them to spend time with family and/or friends as much as they feel capable of. So we also wanted to provide you with a few resources if you think your child is experiencing a crisis. These slides will be posted on YouTube and all attendees will be sent a link after the talk, so don't worry if you don't get these down. So next we will talk about anxiety. Anxiety is generally defined as feelings of extreme worry and fear that are not in line with the actual danger of the situation. For example, someone in a war zone who is afraid to go out of the house would not be diagnosed with anxiety, as it is an appropriate fear. There are 7 types of anxiety disorders according to the Diagnostic and Statistical Manual of Psychiatric Disorders. I won't be discussing panic disorder or agoraphobia here, as these tend to develop in very late adolescence or early adulthood. Generalized anxiety disorder is excessive worry that does not have a specific focus. It has to occur quite frequently for longer than 6 months and may be applied to a wide variety of situations. You need at least 3 of the following symptoms to get a diagnosis: restlessness, fatigue, difficulties with concentration, irritability, extreme muscle tension, and sleep disturbances. You will notice that there's a lot of similar symptoms to depression, and indeed these 2 conditions may occur together. Separation anxiety disorder is unfortunately quite common in autistic children. While all children may go through a stage where they don't wish to be separated from their caregivers, this disorder is much more intense than this usual stage. Autistic children with separation anxiety show extreme distress at separation, often have significant fears of their parents dying, and may worry that they will be kidnapped and taken away from their family. Autistic children with separation anxiety disorder frequently resist leaving home at all, which may lead to an inability to go to school. Separation anxiety disorders continue into the age where most children have gained the ability to separate from their parents. They may have ongoing nightmares about losing their family and a lot of physical symptoms when separated or when anticipating separation from their families. Symptoms have to last for at least 4 weeks, be developmentally inappropriate, and interfere with functioning. Social anxiety disorder is also frequently diagnosed in autistic youth, particularly in adolescents. They are intensely afraid of any kind of social interaction often, and this may lead to an inability to go to school as well. This must last more than 6 months, cause significant impairment, and not be caused by substance abuse or other mental health conditions. Phobias require that the fear be out of proportion to the actual danger. Thus, being afraid of bees might be considered normal, especially if you're allergic. But refusing to go outside because there are bees out there interferes with daily functioning and is out of proportion to the threat. The Diagnostic and Statistical Manual recognizes phobias of 5 sorts: animals, natural environments, for example, heights, blood infection injury or fear of any sort of needles, situational, like a fear of flying, and others, for example, fear of costume characters like clowns. Finally, selective mutism is tough to diagnose in autism because it's very common for autistic individuals to be quite quiet in unfamiliar environments, and it also can be difficult to disentangle from social anxiety. The key here is that it is selective. Children will speak in some environments, but not others. It has to last at least a month, interfere with functioning, and not be due to the autism itself. So in preschool and elementary school, separation anxiety and phobias are most common, whereas as the child gets older, phobias and social anxiety may be more common. In high school, social anxiety and generalized anxiety disorder are more common. And it's not uncommon for one anxiety disorder to morph into another as the child gets older, particularly if the anxiety is not effectively treated. Anxiety can lead to positive things in autistic children, such as those listed here, although most of these positives may lessen as the child reaches diagnosable levels of anxiety. Anxiety is thought to be present in somewhere between 40 and 80% of autistic individuals, depending on the study. It's often due to sensory overload or intolerance of uncertainty, which means that the autistic person always needs to know what is going to happen next. Anxiety can lead to increased rituals and repetitive behaviors, particularly self-injurious behaviors. While social withdrawal may be common in young autistic children, they often seek out friendships as they get older, but may have difficulty interacting with neurotypical peers. With a few negative experiences, they may develop a type of social anxiety, which generally doesn't show a fear of judgment from others, more likely a fear of bullying, which may be justified. Autistic children without anxiety often want to connect with others but struggle, and autistic youth with anxiety may or may not want to connect. Neurotypical individuals with social anxiety generally are deeply afraid of any type of social connection outside of the home. While neurotypical individuals with anxiety generally don't show repetitive behaviors are frequently used by autistic individuals to reduce both normal and excessive amounts of anxiety. So if you do think your child has anxiety, there are several things you can do to help them. Keeping a diary of when they get anxiety and what happened right before can help them identify triggers. If your child has any sort of sensory sensitivity, reducing sensory input can be very helpful. Since intolerance of uncertainty is one of the biggest triggers, keeping visual schedules for your child can help reduce this uncertainty. Try to make sure that you stay calm, even if they're very upset. Modeling calmness can help them feel less anxious over time. And there are numerous relaxation skills like deep breathing and progressive muscle relaxation that can be found on the internet with apps that can be very, very helpful for kids. If they get easily overwhelmed by things that they have to do for school or around the house, break these things down into numerous smaller tasks. Well, you never want to deny what they're feeling and you want to validate their feelings. You also don't want to encourage long-term avoidance. Try to gently encourage them to slowly face their fears and use relaxation techniques and small steps to help them do this. focus on teaching them coping skills rather than promising them nothing bad will happen, as this may not be realistic. Try to get a referral from your family doctor for a psychiatrist that specializes in co-occurring mental health conditions in autism. And modified cognitive behavioral therapy, which is adaptive for autism, has been found to be quite effective. And these are the same resources that I gave for depression. They can be very helpful for anxiety as well. I will now turn you over to Dr. Roncadin to discuss OCD and ADHD.
Thanks very much, Dr. Kelley. So we'll start with discussing OCD. So OCD stands for obsessive compulsive disorder, and it's characterized by the presence of time-consuming obsessions and or compulsions that cause functional impairment. So obsessions are considered persistent thoughts, urges, or images that are experienced as intrusive or unwanted, whereas compulsions are behaviors or mental acts that the person feels driven to perform excessively in response to an obsession in order to relieve distress. Just wanted to give a few more details about obsessive compulsive disorder as a co-occurring condition or formal diagnosis. One of the aspects that I wanted to highlight is that the diagnosis doesn't require both obsessions and compulsions. You'll notice the and or, so it is possible to have a diagnosis based only on the experience of obsessions or vice versa with compulsions. Another consideration is the amount of insight that an autistic person may have into their obsessions and compulsions, and that can actually range from very good insight to very poor or even absent insight. So that's not an exclusion criterion if they're lacking insight. Some of the common ones, which may be familiar to you, are compulsions around cleanliness and contamination, symmetry and order. So you might see a lot of arranging and rearranging things. Numbers and counting is another common one. You might hear a child repeatedly count things or actually express having safe or bad numbers. There may be a lot of checking, excessively checking things like doors, lights, locks, and so on, and perfectionism. And this would be excessive time doing things over and over until they're exactly right or perfect according to their definition. So as with depression and anxiety, OCD can look different at different ages. Here, I've just included elementary school and high school because, in fact, it's extremely uncommon for OCD to present in very young children. We typically diagnose from about 7 years of age up, and that's because the symptoms just don't necessarily present clearly before that. And in fact, the average age for childhood OCD is around 10 years old in terms of getting a diagnosis, but that OCD may not present at all in childhood. And so there's another peak in adulthood. So just because you didn't have OCD as a child doesn't mean you won't potentially develop it as an adult. Another consideration is that younger children tend to experience more frequent and severe compulsions, whereas older children or youth tend to experience more severe obsessions. So just a few examples here. You might see elementary school students seeking constant reassurance. They may actually spend an excessive amount of time using the washroom. Whereas in high school, you may start to see things like hiding their fears and obsessions, being excessively slow completing schoolwork, perhaps based on perfectionistic tendencies. But lots of strengths can accompany OCD, like intense focus, great attention to detail, maintaining routines. And as youth get older, you might see it as determination, creativity, and actually even empathy that's been associated with OCD in older youth. So specifically around OCD and autistics, in the past, we were not supposed to diagnose autism and OCD together. But when new diagnostic criteria were introduced in 2013, we were able to give both diagnoses. And so more current estimates indicate that about 11% of autistic children have OCD, whereas about 2 to 4% of neurotypical children get a diagnosis of OCD. Another consideration is that in general, autistics with OCD tend to be more impaired and are significantly more likely to have other mental health diagnoses compared to neurotypical individuals. So a few examples of some similarities and differences between autism and OCD, as well as what things might look like when they co-occur. We know that autism is a neurodevelopmental condition, so it's from birth, whereas, as I mentioned earlier, OCD presents itself during childhood or possibly later. When they co-occur, we tend to see large impacts on adaptive functioning, like having difficulty leaving home. In autism without OCD, we know that we often see children experience insistence on sameness driven by rigidity. They may have fixated interests. But what we tend to see with autism is that that may change over time. So there might be a variety of behaviors that manifest these characteristics or traits. In OCD, we see situational persistent obsessions, and they're compelled to engage in very specific compulsive behaviors, and they don't tend to change over time. Thoughts in the context of autism generally can be sort of wanted, pleasant thoughts, even if they are kind of obsessive and fixated, whereas in OCD, they're unwanted, intrusive, and purpose-driven thoughts. When they co-occur, individuals can become very rigid and resistant to change, above and beyond what we might see across individuals, across autistic individuals. Another consideration is that, in a sense, the compulsive behavior might actually be positively reinforcing. So when they engage in the behavior, it comforts, it could be for self-soothing purposes, whereas in OCD, the compulsions are very much serving to mitigate or altogether avoid the undesired stimuli. What you may see when they co-occur is that the behaviors may be engaged in to provide comfort. And in particular, you may see a high level of distress if rituals are disrupted. And lastly, with autism, there may be sort of an intrinsic motivation and reinforcement in terms of the behaviors, whereas in OCD, they're highly motivated to reduce or eliminate their obsessive thoughts. They don't want to engage in repetitive thoughts or obsessive thoughts. So it's a bit tricky, I must say, to diagnose OCD in autistics and to really appreciate the separation. In fact, there's obviously quite a degree of overlap in the traits and in the presenting behaviors. So the key is to try to understand the function of the behaviors that you're seeing and the obsessive thoughts if you have some insight or the individual has some insight into them. So if you think your child may have OCD, we want to encourage you to seek professional help, particularly if the symptoms take up more than an hour a day. This is part of the diagnostic criteria, or they interfere significantly with school, friendships, or family life. And I really want to highlight family life. When you have a child with OCD, it tends to have quite a big impact. And so the co-occurrence of autism and OCD will have that exponential impact on your family life. We encourage you to acknowledge their thoughts, feelings, and behaviors. And while the feelings may often be around fears and worries, you might also, in the context of co-occurring OCD, see feelings of frustration, sadness, anger. Reassure that things can get better. In terms of what you can do in the immediate, and minimizing screen time and in particular social isolation can be helpful. We know that screen time and being on their own can actually contribute to distress and symptoms, obsessive thoughts, or really sort of engaging in their compulsive behaviors. And lastly, be patient and learn how to support their OCD journey without accommodating their rituals. And this is a tricky one for parents. You want to work around their behaviors as much as possible. That's natural. But in fact, by accommodating their OCD rituals, you're actually potentially making their OCD worse and making it last a lot longer in terms of being quite severe. And so a few resources for parents and caregivers to highlight. Once again, we want to make sure you're aware of crisis and suicide hotline and kids help phone. But the first bullet is to really highlight in the context of acute onset OCD that you must seek medical attention immediately for your child if you see that acute onset of symptoms. Because in fact, in very, very rare cases, OCD could be brought on by something like a bacterial infection. So please, if you see a drastic change all of a sudden, seek that medical attention immediately. And then there's the International OCD Foundation, which has a wonderful variety of resources for parents that you can access. So we're going to move on to ADHD. Wanted to spend maybe a little bit more time on ADHD because it is so commonly co-occurring with autism. And there are a lot of myths and misunderstandings as well. So ADHD stands for Attention Deficit Hyperactivity Disorder. Symptoms must be present before the age of 12. It is a neurodevelopmental condition, and they must interfere with daily functioning. There are 3 formal subtypes of ADHD. So when someone is diagnosed with ADHD, the professional would typically specify one of these 3 subtypes, namely predominantly inattentive ADHD, predominantly hyperactive impulsive, or a combined presentation of all of those. So let's take a closer look at what these might look like in children. We'll take a look first at what inattention looks like in children. So you might see your child or your student jump from one task to another without completing that first task. They may forget or lose things that they need to complete a task. They may become easily distracted and don't follow instructions carefully. They may have difficulty keeping their mind on a task, or they may get bored of a task easily. So next, let's have a look at what hyperactivity looks like. I think it's pretty obvious from the cartoon figure Tigger there, but what you'll see with hyperactivity is constant movement, lots of squirming, roaming around the environment, touching things. Excessive talking is one that might be less known or understood, and lots of fidgeting behavior. And of course, in an individual child, they may not show all of these behaviors as a manifestation of hyperactivity, but these are some of the ways that you might see it. And lastly, what does impulsivity look like? It might look like difficulty waiting their turn or sharing, speaking or acting without thinking about the consequences, blurting out inappropriate comments, or displaying their emotions without restraint. So equally important, wanted to share what ADHD is not. There are still a lot of myths and misunderstandings out there. So first of all, ADHD is not a behavior disorder. As I mentioned earlier, it's a neurodevelopmental disorder. It's also not an illness or a disease. It's not caused by too much sugar, though diet can play a role in making symptoms worse. It's definitely not due to bad parenting. ADHD does not affect intelligence, and it's also not just a childhood disorder. It used to be thought that people outgrew ADHD once they reached adulthood, but we now know that's not true. So how can ADHD look at different ages throughout childhood and adolescence? Early on, you'll see more of the overt behaviors around hyperactivity, in particular, like constant movement, difficulty waiting turns, frequent incidents with rules. So a little bit more obvious signs in their behavior. As they get a bit older, you'll see ADHD come out in terms of homework struggles. There's often a lot of learning difficulties associated with ADHD. They'll forget materials they need. They'll keep a disorganized desk at school, have lots of social misunderstandings. And then by high school, you might start seeing time management issues, difficulty keeping to their schedule and getting to class on time, procrastination, lots of emotional ups and downs, and possibly some risk-taking behavior with the impulsivity. But lots of possible strengths across different developmental stages. Children with ADHD can be very energetic and curious in positive ways. As they get older, you see lots of creativity. In fact, there are many famous people and successful people with ADHD because of their ADHD. And as they reach adolescence, they can get very passionate when engaged and also show lots of adaptability. So ADHD and autistics, once again, like OCD, in the past, we were not able to diagnose autism and ADHD together, but that changed since 2013. And we now know that many autistics have an ADHD diagnosis or condition as well. In fact, at least a third of autistic children meet the criteria for ADHD, could be higher, as opposed to about 7% of neurotypical children. And recently, we've been hearing this term called ADHD to refer to those that have both autism and ADHD. This is not an official diagnostic term, but a term that you may come across nonetheless. So wanted to just spend a moment talking about ADHD and what's called executive functioning. So executive functions are the brain's management system. They help us plan, stay organized, control our impulses, manage our emotions, and generally get things done. They develop over a long period of time, starting in early childhood and extending right into adulthood. Individuals with autism or ADHD, but particularly ADHD, when both conditions co-occur, tend to have lots of executive functioning difficulties. So you'll see difficulties with planning and organizing and managing their time and maintaining focus. But wanted to highlight 3 particular ways that you might see your ADHD child or youth show these traits. Excuse me. In terms of emotion regulation, we know that both autism and ADHD can affect emotion regulation. When both co-occur, you might see your child struggle very much so with having more intense emotional reactions that then lead to heightened reactions to social situations and stressors in the social environment. And so they might struggle even more greatly with social interactions. In terms of sensory sensitivities, individuals with autism or ADHD can have sensory sensitivities, but ADHD children tend to experience sensory sensitivities in a bigger way. And that overstimulation can lead to outright shutdown or major meltdowns. Lastly, there's this notion of compensation fatigue. And so this is around a constant need to kind of manage and cope with having neurodivergent traits that cut across autism and ADHD and can lead to burnout or feeling drained while trying to cope with that and the social demands in the environment. So a little bit more on similarities and differences with autism and ADHD. In autism alone, we may see attentiveness to small details, whereas in ADHD alone, there tends to be a lack of attention to detail. Similarly with routines, in autism, more so towards rigidity with routines, whereas in ADHD alone, you might see lots of difficulties maintaining routines. As mentioned, lots of difficulties with emotion regulation when autism and ADHD co-occur. In terms of having reactions to new situations, autistics may show excessive resistance to change, whereas ADHD kids may actually not necessarily resist, but have some negative social behaviors. In terms of, lastly, motor movements, we know that there can be repetitive motor movements like rocking, twisting, spinning, and so on as part of autism. In ADHD alone, we see more of the motor restlessness come out. This is not an exhaustive list, by the way, just a few examples. So what should you do if you think your child may have ADHD? We encourage you to make an appointment with your child's primary care physician or with a psychologist. Both will do evaluations of ADHD, but wanted to really highlight what's considered a comprehensive evaluation of ADHD because there's quite a variety of practices out there in the community. A comprehensive evaluation for ADHD should include these components. There should be a review of your child's medical and school records, a developmental history and symptom interview with you. There should also be the use of what we call multi-informant rating scales. So questionnaires that can capture behavior ratings across different informants, typically a parent and a teacher. Part of the criteria for diagnosing ADHD is that the symptoms actually present across different environments, like home and school. There should be a direct observation of your child and possibly some direct testing. There are computer-based tasks, for example, that psychologists often lean on. And there may be additional screening like a hearing test or blood work ordered as well. What else can you do as a parent or caregiver? There are lots of environmental supports and behavioral supports that you can attempt. In terms of environmental supports, one of the aspects to try is labeling things, and this is in terms of helping with organization, where do things belong, but also to help from things getting lost if you've put their name on things that you're sending off to school or other environments. Use of visual schedules and checklists can be enormously beneficial, as well as keeping a consistent daily schedule and routine, and having separate space without a lot of distractions to complete tasks like homework. Behavioral supports include ensuring you have your child's attention before you give an instruction or make a request. If they can, have them repeat the instruction back to you. Use shorter, simple instructions, ideally one at a time if you want success, and help them chunk things. In other words, help them impose organization on information or on materials, and it will also aid in their learning and memory. And lastly, the use of alarms, timers, and reminders can be enormously beneficial. In terms of resources, we don't often see a need for crisis or emergency services around ADHD, although it is possible, but wanted to highlight some of these online resources that parents and caregivers may find really beneficial, namely the Center for ADHD Awareness, which is Canadian, as well as Dr. Liz Angoff's site called Explaining Brains, which has a wonderful set of resources for parents, as well as teachers and professionals around autism and ADHD, in fact, and a newsletter online called Attitude that can be really helpful with some current information that parents and caregivers may be seeking. And that brings us to some key takeaways from our presentation today. On behalf of Dr. Kelley and myself, we hope that you have now learned about many autistics having co-occurring conditions. We've covered 4 of the most common. Want to highlight as well, I believe Dr. Kelley mentioned it, that in fact, it's not just one co-occurring condition. Autistic children, youth, and adults can actually have more than one co-occurring condition. So autism and ADHD and anxiety, for example. Just like autism, co-occurring conditions may look different across developmental stages and various situations. Parents and caregivers know their children best and can tell when there's been a change in their child's previous baseline. So really important to rely on your instincts and seek professional input if you think your autistic child may have a co-occurring condition. And we hope you've heard and learned about various ways that you can support a child's co-occurring conditions. You may have noticed that we didn't really speak about medication in this presentation, but I would be remiss if I didn't comment on the fact that you may have a discussion at some point about the role of a medication in supporting your child's co-occurring condition. We're so grateful that you took time today to join us for this discussion and hope that you're taking away a better understanding of co-occurring conditions and that you have some strategies under your belt as a parent or caregiver. Thank you so much. We have provided our emails on the next slide.
Thank you both. I will just dive right into some of these questions. At what age is testing for anxiety possible, and how might it be identified in nonverbal children?
Anxiety can be tested for in preschool children for sure, although it probably won't get diagnosed until later in early childhood. And sorry, what was the second I got?
How might anxiety be identified in nonverbal children?
Yeah, so that's a very, very difficult one. There are some instruments that are designed for those with intellectual disability that can be used for minimally speaking autistic individuals, but you would really need a specialist who had experience with autistic individuals who are minimally speaking for sure.
Yeah, agreed. And I would just add that at least as a psychologist, our approach as psychologists might be to lean a little bit less on standardized tools like questionnaires and other direct testing, and more on direct observation across different settings and circumstances to see what might provoke the anxiety. And of course, lots of interviewing of people who know that child best and can really speak to how the anxiety might actually present itself.
Wonderful. I'm going to transition right to the next question. Somebody has read that CBT might be less effective for autistic youth. Is that true? And if so, what other therapy methods might be effective?
So CBT generally needs to be adapted for autistic youth. These adaptations include extending the amount, because CBT tends to be very short, like eight sessions or so. So you need to extend the amount so that you're not presenting so much information at once. You also need to include more information on sort of being aware of emotions and what emotions are and those sorts of things, and what anxiety is, what it feels like. There's a lot of visual adaptations for autistic individuals. There's more involvement of the family generally than there is with neurotypical children. But there has been a lot of research that has shown if those adaptations are made, that it is quite effective for anxiety in particular. If they're not made, then you're absolutely right. It's not very effective.
And maybe I'll just add to that if it's not possible or not proving to be effective, one of the strategies that we might take is to sort of step it back from the cognitive aspect of therapy to more of a behavioral aspect of therapy, in terms of really focusing on how to help support a shift to behaviors that will reduce the condition of anxiety.
There was a question that came through the Q&A wanting to elaborate a little bit more on the concept you mentioned of compensation fatigue. Could it present like something like anger or degrees of shutdown when a child might be told not to do something, for instance?
Yeah, absolutely. I mean, I think this concept falls on a continuum, right? There isn't sort of an all or nothing aspect to it. But wanted to highlight that when there is a co-occurring condition like ADHD, that you might be more likely to see that sort of compensation fatigue. You might get bigger meltdowns or a complete shutdown, which can be really scary for parents and caregivers, of course, but hopefully rather temporary with support.
A bit of a broad one, but maybe it's something to end on in terms of, are there important practice recommendations for educators, like in the classroom, to better support the mental health of autistic students? Understanding that you two are not teachers, but you did mention a lot of strengths in your presentation. So maybe there are some things to pull into that particular environment.
Do you want to, you can answer this, Caroline, if you like, or
I'll jump in and first, and you jump in as well if as you see fit. I would start by saying that, you know, really being aware as educators of the high rates of co-occurrence of mental health conditions with autism is so crucial, as well as the concept that Dr. Kelley introduced of diagnostic overshadowing. If even when there is a recognition of a change in behavior or emotional status in a student at school, there might be sort of a natural tendency to chalk it up to autism, right? But to really sort of resist the temptation to do that and really wonder about whether this change from the usual or baseline might in fact be a signal of a mental health condition. And I think the other is to seek out supports. Every publicly funded school board has supports for students' mental health, as well as supports for autistic students. So get some additional support from the special education department.
and I think some of the recommendations that we made for parents would be helpful for teachers as well. Things like, you know, not being afraid to talk about feelings, not denying feelings, keeping track of what causes the child to become anxious, and those sorts of things.
Mm-hmm. Wonderful. Thank you, Beth and Caroline, for your very interesting and informative presentations.